Okay, we're back, and we were talking about diabetes and diabetes control again, and its effects on our eyes and what we can do to help to avert that. And again, remember I said that the best thing you can do is get in to see your eye doctor and let them do an intensive dilation exam of your eye so they can look in the back and there and can actually see what's going on in your retina and making sure you're not developing what we call amyloid deposits, which are things in the retina, and also the neovascularization. The other things you'll see with regards to the eye is what they call the AV crossings, or arterial venous crossings. They normally should be in a kind of almost like a figure, almost kind of overlapping. And then as blood pressure tends to become an issue, they may actually, what they call turn in this way. They'll actually start to have a perpendicular appearance, and then they'll tighten one another. It's not really related to diabetes, but it's another finding that you actually see when you look in the back of the eye and see what's going on there. So it really is pretty simple. I mean, you get depositions of, I'm going to get tangled up in this cord here. You get deposition of basically stuff in the lens that can make it thicker and harder, and then eventually you'll develop cataracts, which is not related to diabetes. Cataracts is totally related to age, and then maybe a genetic predisposition for that. So it's very important to realize that, cataracts, if you go into the eye, they're going to see that, and then they can be repaired, but they have no issues with diabetes. The other thing is glaucoma. Glaucoma is not a diabetic-related disease, and it is something that you do need to check, and the only way you do that is they do a real air test. I remember when I was in medical school, we had to actually put a numbing drop on the eye and actually press something against the eye. Now they just do a little wisp of air, and you get your pressure in your eye. And it's a subtle cause of blindness because the pressure actually destroys the peripheral part of the retina, not so much the center part of the retina. And most of the vision takes place in what we call the rods and the cones, which are the simple parts of the eye than the center part. And in the peripheral part of the vision, there's very little distinction that takes place. You can make out light and shadows, but you actually can't make out detail. So most of your vision takes place in what we call the macula, or this center part of the eye, which is not actually straight through your lens. It's actually offset by 10 degrees, where you get this very high concentration of rods and cones, where you get the vision, the acuity from that particular area. So macular degeneration is one of those things they're doing a lot of work on. It is also not related to diabetes per se, and it seems to be, taking a good vitamin dose of zinc and maybe a vitamin D and everything may help to prevent what we call macular degeneration, or a disruption of those eyes. And hopefully that's not something that you have going on, because it does lead to progressive blindness, and there really is no cure at this particular point, and science really doesn't have anything to talk about that. So I'm going to shift a little bit towards diabetes related to the kidneys, another microvascular situation. Our kidneys are filtering organisms or organs, and basically the whole idea behind that is they let certain substances through the filtering system, and they reabsorb those through the collecting system. But there is a thin basement membrane, kind of a so-called semi-permeable membrane, where things are not allowed to go through. And what is not allowed to go through is protein. Protein is what we call the colloid, or the substance of your blood. If you've ever seen your blood being spun down, there's red blood cells and white blood cells, but when they spin it down, the clear part of that is serum, and the serum actually has a lot of proteins and chemicals and other things that are in there. Those proteins that we make in our liver, albumin is whatever, but there's a bunch of other proteins, immunoglobulins and things of that nature. And if for some reason diabetes, being high blood sugar, causes a damage to that basement membrane or that filtering system, the protein starts to leak into the kidneys. And what we start to see initially is what we call microalbumin. Microalbumin is a smaller portion of albumin, but it basically is a harbinger of a worse thing to happen, meaning microalbumin is the first stages of leaky kidneys. Now, there are a lot of diseases that can cause leaky basement membranes. There are some autoimmune diseases such as rheumatoid arthritis, systemic lupus, things of that nature, which for somehow your body turns against its own connective tissue. Well, what is connective tissue is the basement membrane. So what happens there is your body starts to destroy that basement membrane, which allows leaky protein and things to go through your kidneys, and they cannot be reabsorbed at the rate at which they're being expelled. So therefore, you spill them in your urine. And protein in the urine is a very ominous sign for the risk of heart disease with diabetes. In fact, most doctors are screening for the patients by looking at their microalbumin in their urine. And that's usually the first thing. Now, control of this issue can sometimes be gained with tighter blood sugar control when you're younger, in the 6 to 6.5 range. But when you're much higher than that, you're going to be spilling a lot of sugar into your urine, and the body tries to reabsorb that, and it will do so. Normally, the cutoff is 200 nanograms, 200 nanograms per deciliter of a blood sugar of 200. Meaning, once you go above 200, you're going to spill it into your urine. However, because that system actually ramps up, it could be as high as 220, 230 if you're running chronically high blood sugar. So the idea of your blood sugar, testing your urine, the more you spill, and there are drugs now that actually do that for you. They're called the SGL2 drugs, the Farxigas and the other drugs that are out there on the market. And those drugs really enhance excretion of sugar. They actually do not allow your body to reabsorb the sugar. So it is a way to eliminate sugar from your body. Obviously, the risk of infections happens to be there because you're going to be spilling urine, sugar into places that you're normally not doing. So urinary tract and yeast infections and things like that are on the up when they do that, as they would be if you were letting your sugar run high. But soon enough, the basement membrane gets more leaky, and then you start to get the microvascular complications of atherosclerosis affecting the what we call afferent, efferent portion of the kidneys. So your renal function starts to deteriorate. And the next thing you know, you're in stage 4 or 5 kidney disease, and you're looking for dialysis. So that's a situation you want to avoid, and tight control at a younger age will prevent some of the late stages of renal destruction. There is a thing called time under the curve, and what I mean by that is that if you spent a lot of time with high blood sugars when you were younger, that destruction of those tissues becomes additive over years. It becomes a cumulative phenomenon. 1 or 2 years of bad sugar control probably will not make that big of a difference. But when you start at a young age with horrible control in your 20s and 30s, and yet you do that, then you've got then let's suppose you had 2 years of bad control. Well, what is 2 years? Well, now you got the effects manifested over the first year and then the second year. So now you actually have 3 years of bad control. I hope you understand what I'm trying to say. And if you're now going out 3 years of bad control, you have 3 plus 2 plus 1. You have this cumulative effect of multiple years of bad control. 4 would be 4 plus 3 plus 2 plus 1. It's not just 4 years, meaning the first year the bad control started and it's lingered for 4 years. Now you've got the bad control starting at the end of the second year and it's lingering for 3 more, and then 4 more, and then you've got this cumulative effect. And so it's time under the curve, and that's why the longer you're out in left field doing whatever you want, the consequences become greater and greater and greater. And once you reach a line in the sand where you've actually hurt your kidneys or had a heart attack or done something along that line, you can't go back. You now become a patient in a different ballpark, and tight control or everything like that will not undo the cumulative damage that you did for those years of not paying attention to what you need to pay attention to. So that's why lifestyle modification is the #1 recommended issue for diabetes control. And it is a proper diet, and it is proper exercise, and in learning how to control those things. And that's how you basically tend to prevent this cumulative effect of long-standing diabetes. And listen, I'm here to help you understand what that is, but I can't do the work for you, as I tell patients. And I've actually discharged some patients because they just don't get it, and they just don't want to get it. And I'm like, why are you wasting my time? I mean, I can't do anything for you. I can't be there to do it for you. It has to be you, the one doing the issue. I'm not the one that's going to do that. And the way the legal system is they might hold us responsible at some point for your negligence. And I refuse to be a part of that because you just can't get a decent diet, and you can't get exercise, and you can't do something positive for yourself. With that note, we're going to take a break, and we'll come back for the last segment. And again, I really thank you for tuning in. Thank you.